So my name is Smriti. I am a fourth-year resident. If you don't know me yet, it's a failure on my part. But welcome to my social EM lecture about immigration and healthcare. So I want to introduce this topic with a fairly typical story. So you have a 46-year-old Venezuelan woman. She presents with worsening shortness of breath, leg swelling, can't lie down, can't walk 5 steps. She works 2 jobs during the day. She also works as a home health aide, sometimes at night. You look for a translator phone, you can't find it, it's really busy, you get some limited history, work her up for what basically ends up being advanced heart failure. She tells you that she's had a family history of early heart disease, and most of her family is in Venezuela, where 70% of the country's children are malnourished owing to the economic and political crises that they've been going through for a couple of years. And she fled with her 2 kids so that they can basically get to survive. She tells you she doesn't want to be admitted because she can't miss work. She has to leave AMA. Thankfully, we're in a safety net hospital, so you can start her on some of the cheaper heart failure medications through our county pharmacy, even though we try your best to keep her. She arrives in APE a few weeks later because she ran out of her meds, but couldn't get time off from work to come to the ED to get them. She couldn't stick with the strict diet that you prescribed her due to affordability issues. And you tell her that she can get help applying for Medicaid. But she tells you that she's ineligible because she's actually been in the country illegally now for over a year and is afraid of getting deported. You then suggest that she ask her employer to give her a day off, and then you offer to write a note so that you can excuse her from work. But she tells you that her employer actually last time refused to pay her for a shift because she missed another shift, and she can't actually do anything about it because they know her immigration status and therefore they have that leverage over her. She further doesn't want her employers to know that she has a comorbidity because she doesn't want to create problems. She doesn't want to be replaced by another more able person. And she's worried that they may fire her and then she has no income. After she's stabilized, she leaves AMA during admission. And then you have no idea what happened to her afterwards because she's never seen Kings County ever again. So this story outlines just a small portion of how difficult it is to access care when your very existence in this country is deemed illegal. This is an extremely complex subject, numerous variables, particularly in terms of policies and challenges. They vary from state to state, and they also vary from immigrant to immigrant, depending on why you're here. And the goal of my lecture in these 30 minutes to encapsulate this large, massive global tragedy really, is to kind of give you a broad picture of the scope of this issue. Some of the general principles of immigration as a social determinant of health, its general impact, and some ideas of what we can do in our own context. So just to talk numbers first really quick to get an idea of how many people in this country are part of this vulnerable population. So out of the 11 million undocumented people in this country, 6 million of them are uninsured. So that's more than half of them. And then in New York City, we have 250,000 undocumented and uninsured residents. And just in Brooklyn, this is around 60,000. So 60,000 both undocumented and uninsured, 125,000 who are undocumented. And the disparity here is that despite making up only 3% of the country's population, undocumented immigrants make up 20% of the total number of uninsured people in this country. And this is disproportionate, highlighting this primary health disparity that this population faces, which is access to affordable healthcare and healthcare coverage. Let's take that one step further into Brooklyn. Specifically looking at our catchment area. So New York City has 500,000 undocumented immigrants, and most of them actually reside in Brooklyn and Queens. As you can see, we have 1/4 of them. And then obviously Queens has the most. And then if you go into our catchment area, between Flatbush, Midwood, East Flatbush, Lefferts, Crown Heights, we've got about 120,000 undocumented patients. And so that's 99% of the patients in this population. Between us and all the other safety net hospitals, we take care of most of them. We're also the largest safety net hospital between Manhattan, Queens, and Staten Island. And so the proportion of undocumented immigrants in our hospital is likely larger than what just that catchment area has. So what is available for them currently? What are their options? So nationally, the 11 million undocumented immigrants here are systematically excluded from almost all federal health insurance programs. Medicaid, Medicare, the Affordable Care Act marketplaces, and also the Children's Health Insurance Program. Some states may make some provisions for varying conditions, but they're limited and they're conditional. There's always a then what left in your mind after you read these policies. So for example, 16 states provide prenatal care to all women through CHIP. which is a children's health insurance program, regardless of immigration status. But then what happens after that? What happens after labor? And then 6 states and DC extend Medicaid to kids under 18, but then again, what happens after they hit 18? Refugees also are generally eligible for Medicaid, but then only for the first 7 years of existence. And then what? Asylum seekers qualify for ACA exchanges, but only at 6 months after applying for asylum. So in those first 6 months, they're completely vulnerable. And then some states extend Medicaid and CHIP to lawfully present children and pregnant women without the 5-year wait. However, seeking asylum status is very difficult, and if you don't get granted, then you just put yourself in the mouth of the tiger, and you risk deportation. And so a lot of immigrants see this as a risk, and they do not seek it. Currently, Medicaid payments for emergency services are the only federal funds allowed for undocumented immigrants because of EMTALA, essentially. So federal law requires hospitals to stabilize patients with life-threatening conditions, irrespective of immigration status, but not much else. And so consequently, half of the undocumented adults under 65, so the workforce, and a third of undocumented kids are uninsured. And so for basic medical care, immigrants often turn to these federally funded healthcare centers. I know Alec worked at one in the past, and they provide services on a sliding scale based on ability to pay, irrespective of residency status. There's 1,400 of these across the country, caring for at least 6 million undocumented uninsured people, which leads to significant health disparities. Their numbers are worse in every sense of the word. So trauma, morbidity from preventable diseases, postpartum complications, childhood morbidity, sexual violence, ESRD, and liver disease. And that brings us to the conclusion that immigration status is a very real social determinant of health. To drive this point home, this is a graph outlining the disparities just based on citizenship status in New York City, which arguably has better care for immigrants than a lot of other states on the East Coast. And the proportion of undocumented residents in New York City is not negligible. It's projected that 13% of all families here have at least one undocumented member. But they still have the worst of everything compared to citizens and also legal non-citizens. More of them earn below the poverty line, live in overcrowded living conditions, have limited English proficiency, make up more of the essential workforce, and the widest disparity of all, about half of them have no health insurance, as opposed to 13% in legal non-residents, non-citizens. Which then brings me to the problem of access to care. Immigration status influences health outcomes by determining how easy it is for you to get care. And let's take it back to our case from the beginning. And identify which components of social determinants of health are rooted in this woman's immigration status. So first up, you've got healthcare access and equality. Who can identify her barriers to access? Anything? Okay, so yeah, go ahead.
Like for her job, for example, like she feels like she won't necessarily be able to take off.
Absolutely, she's got economic vulnerability, right? Anything else?
Also,
childcare.
Huh?
Childcare.
Childcare, good.
A lot of patients, unfortunately, have this mistrust that if they're undocumented, they think if they come to the hospital, that will report them, so they were less likely to want to come. Absolutely,
you drove the point home there. Fear of deportation is one of the biggest barriers to seeking care, seeking pretty much anything here. She also is ineligible for federal, all three of these. So she's ineligible for, she's ineligible for federal insurance, so she has to rely on the ED for care. Because the ED is always busy, she doesn't necessarily get the benefit of having access to translator phone. She can only get certain medications based on her eligibility, and since insurance is a prerequisite for getting an organ transplant, if she ever does develop advanced heart failure, even though for her age she would actually be eligible, she likely will not be able to qualify. And therefore, healthcare access and quality determine her outcome as a result. In terms of economic stability, Priyanka mentioned job insecurity, basically. Despite the fact that she does have employment, if her employer decides not to pay her or exploit her or refuse to give her sick days, she can't do anything about it because of fear of deportation. She also can't debate her income despite how much she works, which can make it very difficult to afford insurance to begin with. And then in terms of her social context, fear is one of the worst things that they have to deal with because everything they do is risk. Seeking asylum, which would give this woman some rights, is a risk because if she isn't granted it, she'll have to go back to Venezuela, which is not an option for her. It seeps into every decision they make, making them unable to access care that would otherwise be available. It also places undocumented immigrants at higher risk for violent injury, re-injury. It makes them less likely to report crime, so they're even more vulnerable. And then they are also more susceptible to sexual violence and domestic violence, leading to earlier morbidity and mortality. A couple of other special considerations to think about are, trafficking. This is an entire lecture in itself, but fear of agencies like ICE also places them at risk of workplace exploitation, also known as labor trafficking, as well as sex trafficking. This is another very vulnerable population among an already marginalized community. And the numbers here are very uneven as well. So 67% of labor trafficking victims are undocumented. And then 13% of sex trafficking victims are undocumented migrants. Undocumented transgender patients are another extremely vulnerable subset here, as it is even as citizens. Transgender patients face significant health disparities, and it becomes basically impossible for them to maintain gender affirming or often life-saving treatment if they don't have insurance. Prenatal care is often very sparse as well, with fatal or non-fatal complications in both mom and baby, which further causes morbidity and resulting vulnerability in the next generation. And ESRD, this one is very relevant to us, and we all have an idea of what's going on here. Nephrologists across the country have long advocated for undocumented immigrants to be able to get scheduled dialysis, but they've been fought pretty much at every step of the way. We can relate to this a lot more than other institutions because this is such a prevalent issue for us. They do need to rely exclusively on ED dialysis, which is much more expensive than being able to go to a dedicated center. And the thing is that dialysis is life-saving, so it is more likely than not that somebody who needs it is going to end up on death's door at your ED, which eventually ends up not only costing much more in the long run, but also does not have very much of a positive prognosis in the long run. There was a study done in Texas on the specific population, and a group of nephrologists did it because they wanted to prove that scheduled dialysis was significantly cheaper than just ED-only dialysis because everybody on the other side has been complaining about it. So they found that scheduled dialysis was significantly associated with reduced one-year mortality, healthcare utilization, and costs compared with emergency-only dialysis. We have patients at our institution who regularly come to us for scheduled HD, but New York is only one of the 10 states that actually allows for this. And in the remaining 40 states, they can only get emergency dialysis, which literally means you can only get dialysis if you're on the brink of death. So if you are, if you have life-threatening hyperkalemia with unstable arrhythmia, or if you're uremic, a significant acidotic altered, et cetera, your AEIOUs. And the messed up thing here too is that the definitive treatment for ESRD is organ transplantation. And 3% of all organ donors are undocumented, but most of their organs go to citizens, and the numbers of undocumented immigrants receiving organ transplants is extremely low. And the reason for this is that while the National Organ Transplant Agency does not kind of discriminate based off of immigration status, they do need you to have insurance, and since they don't have insurance, they're often not eligible. So the consequences of poor care for undocumented immigrants they're on a very large scale. It's not just individual or not just on a few people. On an individual scale, there's significant, increased morbidity and mortality, loss of life limb in individuals and also families as a result, mental health consequences, loss of income, and kind of a general descent deeper into that cycle of worsening social determinants of health. Everything is just worse when you're sicker. You depend more on healthcare. You can't have access to it. Your ability to work and pay for it is down, and your ability to provide for your family is also reduced. Public health experts have also made the argument that withholding care from this population poses a risk to public health. A large percentage of them are essential workers, for example, like in the food industry, and if they don't get the care that they need, there's increased risk for spread of infectious diseases like TB. Not even to mention COVID here. But there's another public health risk that is a little bit more abstract in nature, and that is for the future. In 2018, it was projected that 40 million people, or 12% of this population, have at least one parent who is undocumented. They're not an insignificant part of our economy, and decreasing their access to care also places these 40 million people into the cycle of socioeconomic vulnerability. If parents can't work or support their children financially, this places a barrier to education and their ability to pursue proper housing, careers, and healthcare. If a child is born to undocumented parents, they do become a US citizen by birth, but then the likelihood that mom did not have prenatal care is also high, which causes the child to have complications or NICU stays, causing a lifetime increased healthcare requirement, costs, and other issues in the future. And this leads me to my next point, that there are impacts even for the business aspect of healthcare. They have lifetime increased ED utilization overall, which is covered federally for undocumented immigrants. And this is often with little to no positive ramifications to the inability to get definitive care. And ED utilization is more expensive, causing more costs than it would if they had access to preventive care, just the same as everyone else. Economic analyses have demonstrated that the break-even point, for example, for a kidney transplantation is being on dialysis for 3 years. So if you, at 3 years, it's probably better for them to get a transplant, but they keep coming in for ED dialysis because they can't get transplants. In addition, undocumented patients Medicaid have post-transplant outcomes equal to those of US citizens. So there's another argument from the previous administration that patients with limited financial resources are not able to adequately maintain their health post-transplant, but this is refuted by that data. And then globally, this is not an issue limited to the US. We just have this large scale human tragedy of multiple populations around the world going through death and disability, while healthcare systems in many countries, including the US, can't do anything to help. Poor care for undocumented immigrants is one of the many, many, many reasons why the US is behind in terms of being a moral leader, despite being a quote unquote superpower. And so, as you can tell, this is a very large scale problem. It's got many intricacies and challenges that vary by state, they vary by immigration situation, also by politics. Our last administration highlighted how vulnerable these populations are to any change in the political climate. And now that I've sufficiently depressed everybody, as it is with most of our social EM topics, it's very easy to feel helpless and overwhelmed when thinking about how you're gonna find a solution. But this is not a problem without a solution. It's a problem that requires many different solutions on different levels. And we have to start with ourselves, right? Because it's really hard to think about the world if you can't fix things in your own context. So there's a quote from Annals that says the ED is singled out as the only component of the medical system, and in this case, the only component of the entire social welfare system that is protected by law for many of the most disadvantaged. And so the answer starts with us. How does all of this relate to us as ER docs, and particularly at NYCHHC, which is a safety net hospital? What can we do in our context, and how can we create an immigration-informed emergency room? Okay, well, you get the point. Okay, so on an individual level in your emergency room, what can you do? So you can reframe discussions on immigration status away from polarizing political topics to one that directly impacts patient care. At NYCHHC, this is particularly important because, as mentioned earlier, most of New York City's undocumented patients come to the HHC hospitals for care. Us being the first providers and often the only providers, we need to have a robust understanding of the social determinants of health that affect these patients, and we should continue to educate others in our healthcare system as such. Part of this is also understanding the demographic composition of your ED, wherever you go. What is our local community comprised of, and where are most of our immigrants coming from? Understanding that cultural, structural, and global condition in that community, and also the conditions of the country that our immigrants are coming from, shapes how their ED visits go. Because you can start to recognize patterns and perceptions of healthcare, as well as their traditional practices and factors that drive immigration out of other countries. In Central Brooklyn, actually most of our undocumented patients still are from Central America and Latin American countries, actually beating out Caribbean and West African patients like you'd think. And then the largest concentration of undocumented patients is actually in Southern Brooklyn, and so you may often come across them at Lutheran. And then the simplest thing you can do to make your practice more immigration informed is just using the translator phone. Kind of just the simple act of making it easy for them to communicate with you contributes to having a more immigration informed workflow. This is a direct statement from the Civil Rights of the Department of Health and Human Services, essentially saying that every single person, regardless of citizenship status, has the right to healthcare in their own language. And then on a community level, it starts to get a little bit more difficult, but you have to involve your hospitals and your community's resources into giving immigration-informed care. Undocumented patients may be denied access to care, to health promoting services and treatment modalities that are available to other people, like your wound care nursing, public programs, and some medical therapies also falling to search from the ED. We have to work with our social workers and community-based providers to give tailored care. And I understand that that's very difficult, but we have to start. That's where we have to start because they're the ones that are going to have these conversations. We should also know what our state and our city has in store for our patients, what resources we have, because New York City actually does have some better policies for them than a lot of other major cities. So it's important for us to know. And then lastly, we should also be aware of the types of immigration relief are most relevant and available to the ED. I think the intricacies of immigration relief are sort of out of our purview, but understanding some of the basics can help you bring attention to specific patient populations and disease presentations. And there also should be a kind of an awareness that a multitude of barriers have been erected systemically to limit asylum and immigration relief. So we should take care not to promise immigration status adjustment, but refer them to qualified legal advocates to avoid misinformation. And that's for strengthening your ties with local legal partnerships, community-based organizations. These can facilitate linking them to social services because they do understand the challenges much better than we can. They have much more access into the community and they do a significant amount of outreach. And then on an advocacy level, be empowered to know that we're in a unique place in healthcare where we have a window into these specific issues and we can use them to lobby for those patients. Advocacy against humans being illegal is intertwined with professional ethics, right? And our principle that healthcare is a human right. So you can engage in local and national organizing to address these barriers to care and also involve these communities in your efforts so that there's some matching between advocacy efforts and need. Finally, I want to talk about something really huge that New York City has actually done this year. How many of you know about NYC Care? That's excellent. Okay, a couple of us, Schechter, Hassel, Sinnert, and Lucchese. All right. So this is a $100 million program through NYCHHC to cover all residents of New York State who do not qualify or cannot afford health insurance based on federal guidelines. It doesn't explicitly say undocumented in the title, but de Blasio actually introduced a program with that population in mind and used that term when he spoke to the press in 2019. It's a pretty big deal. I don't think any of our social workers have really talked about it with our patients. I didn't know about it until I was looking up stuff for this lecture. And it is the closest thing we have to single payer healthcare in New York City. It's basically a membership program. It's very explicitly not an insurance program. And anyone, regardless of immigration status or ability to pay, can get healthcare. So as of February, they have 50,000 enrollees in New York State. Many people from the Department of Public Health, like Chelsea Cipriano, some of you may know her as Taylor's wife. She has been doing a lot of outreach so that people can sign up for it. And providers in the clinics sign up for it as well. This should be happening in the emergency room, but our social workers don't know about it. So it's something that we can talk to our patients too. We can just tell them, hey, do you know that you can get free healthcare and not have to wait in the ED to get your medication refills? Something like that can go a long way.
It's only good for the H&H system.
Yeah.
I think that's important to remember. So which still has, like in our neighborhood, a lot of flaws. It means they're stuck going to an H&H clinic. It's not like they can go to any doctor with it. Which it's definitely really good for New York City and for those in New York City who don't have access to healthcare, but it does have limitations.
Yeah, absolutely. I should have mentioned that this is an NYCHHC initiative only.
And they have to go to an NYCHHC pharmacy as well?
Yeah, they have to go to HHC pharmacies. I don't know the exact details, but I think there are some other pharmacies that are subsidized under this program so that they can access them, and they're specifically located in pockets where there's more of these patients.
They had a big launch, but that was before COVID. I think everybody forgot.
Yeah, it was de Blasio was trying to roll it out in 2019, but then it was just a few months before COVID, and then it was put on hold. And so not a lot of people know about it because the advertising kind of fell apart. So 50,000 is a pretty small number, given the fact that we have 240,000 undocumented people in the city. But hopefully this is an upward trend, and we're able to introduce more of our patients to it. Here's a few links for resources in the city and our community. There are quite a few, so if you can reach out to me, I'll send you the whole list. There's just too many to list over here. And kind of a little bit on a personal note, last week I was sworn in as a citizen of this country. And to prepare for this test and this occasion, I viewed the Declaration of Independence. It's embarrassing, I didn't read it for 15 years, but two things stuck out to me in this declaration. So one, that all men, ignore that exclusivity there, are created equal, that they are endowed by their creator with certain unalienable rights, and those are life, liberty, and the pursuit of happiness. And the thing with life, right, is, especially for us as doctors, we know that life does involve having good quality and accessible healthcare. So all those arguments by the last administration about who deserves healthcare are moot. The original Declaration of Independence implies that everyone here has this unalienable right. I have the incredible privilege of becoming a naturalized citizen here. I know what that means for my future. And compared to so many others who came here but don't have this right, don't have this privilege. And kind of, it's always the first step for any of these social media lectures is kind of being aware of your own privilege. It is the first intrinsic step you need to take so that you can engage in these discussions about patients and contribute to them positively. These are my references, and a special thank you to Dr. Kendall, who was helping me with this lecture amongst diaper changing and bath time, and Chelsea Cipriano, which is a huge help. She was the one who actually showed me towards NYC care. Thank you very much. It's been a real pleasure.